Evening, everybody. My name's Kathy Daniel. I'm the Acting Head of Nursing Department at the University of Melbourne. I'd like to thank you for joining us for the first of our 2025 public nursing lectures, and tonight's presentation is titled Trauma-Informed Nursing for Safer Care Practices. I'd like to begin by acknowledging the traditional owners of the land of which I'm joining you from this evening, the Wurundjeri Woiwurrung people of the Kulin Nation. I pay my respects to elders past and present. I'd also like to warmly welcome any Aboriginal and Torres Strait Islander colleagues with us tonight, and I'd like to acknowledge the work that First Nations nurses do in educating us to provide culturally safe care. I'd also like to acknowledge the traditional owners of the many lands that you are watching from tonight. This year, I'm delighted to share that the University of Melbourne is partnered with Peter MacCallum Cancer Centre, the Royal Children's Hospital, the Royal Melbourne Hospital, and the Royal Women's Hospital in the Nursing Event Series. And I'd like to acknowledge colleagues from our partner hospitals, Adjunct Professor Kathleen Fallon, Adjunct Professor Kath Riddell, Associate Professor Andy Dimmick, and Chief Nursing Officer Laura Bignell. We really look forward to presenting another insightful nursing series of lectures with you this year. In 2023 and 2024, our lecture series delved into the issues of equity in healthcare, and this year we will continue to extend that theme. Our 2025 series has been created under the theme Nurses Driving Change and Leading Impact, Evidence and Experiences from the Field. Nurses are ensuring that equitable and safe and high quality healthcare is fundamental to the performance of our healthcare system and excellent patient outcomes. Nurses are positioned at the crossroads of primary, community and acute health services and play a pivotal role in navigating timely access and advocating for system improvements to meet the diverse needs of all individuals seeking healthcare. Each of the expert presenters here tonight and who have been invited to speak will expand our understanding of equity issues in the field and discuss how we can strengthen nurse-led care by optimising practice, using research and fostering collaboration for better healthcare. I'd now like to warmly welcome Bronwyn Tarrant, who'll be our MC this evening. Bronwyn Tarrant is a mental health nurse and adolescent psychotherapist. She is specialised in post-traumatic mental health prevention, research, treatment and workforce education, and she's consulted with ANU's Australian Child and Adolescent Trauma, Loss and Grief Network and the Australian Red Cross. Welcome, Bronwyn.
Thank you, Kathy. Hello, everybody. It's my pleasure to introduce you to today's seminar topic, Trauma-Informed Nursing for Safer Care Practices. Today, we will explore the critical role of nurses in advancing trauma-informed care practices, emphasising prevention, safety, and, as Kathy said, equity in healthcare. Our panellists will offer different perspectives on how nurses play a key role in leading trauma-informed practices, aimed to foster trust and engagement by ensuring psychologically, psychosocially and culturally attuned care, enhancing the well-being of patients, staff, family and visitors. With this in mind, I'm very pleased to introduce our panel. Dr. Hayley Peckham combines philosophy, mental health nursing, psychotherapy and neuroscience with the lived experience of complex trauma. Driven by her work with children in care, she pursued a PhD in neuroscience to understand how experiences shape the brain and life trajectories. Her research promotes non-pathologizing trauma-informed care, emphasizing relational practice and social justice for those affected by trauma and inequalities. Kelly Light is an experienced paediatric nurse and educator, dedicated to health access and equity for infants, children, young people and families. As the Royal Children's Hospital's first ambulatory clinical nurse educator, she supports nursing education across community and outpatient teams. Through clinical education and research, Kelly champions holistic well-being for patients, families and staff. Ria Esbury is the head of mental health liaison nursing at Peter MacCallum Cancer Centre, with over 13 years of experience in acute and subacute mental health settings. With advanced qualifications in mental health nursing, she educates oncology nurses on trauma-informed care to improve patient outcomes. She's a senior lecturer at Swinburne University, and Ria is committed to bridging the gap between mental health and oncology through education, advocacy and research. Kelly Gum is Australia's most experienced trauma program manager, with over 30 years in trauma, critical care, education and research. She's led the development of trauma guidelines, authored key learning resources, and coordinates multidisciplinary trauma education at Royal Melbourne Hospital. Kelly is dedicated to improving the patient outcomes through high-quality, seamless trauma care. And Claire Manning is Director of the Social Model of Health at the Women's, where she has been driving cultural change to embed trauma and violence-informed care across healthcare services. A social worker and family therapist with extensive experience in mental health, substance issues and child protection, Claire leads a team committed to addressing social determinants of health and improving care for all patients. After our presentation, we will have a panel Q&A session. You can pose your questions using the Q&A tab at the bottom of your Zoom screen. Once again, thank you Hayley, Kelly, Ria, Kelly and Claire, and thank you to the hospital partners, and thank you to all for joining us for these important conversations. I now welcome Hayley to present.
So let's go back to the neuroplasticity. Thinking of experiences as being a little like raindrops. That each single raindrop or experience doesn't have much impact, but collectively many raindrops really do. And many experiences do too. So the rain falls on the land, it forms these puddles and flows down the path of least resistance. And that's what experiences do. They kind of land on the brain, they form these neural pathways, and the experiences travel down those neural pathways. The rain flowing wears a channel, just like experiences do in the brain, and the next time it rains or there are more similar experiences, they flow down that path already created. So repeated rainfall creates streams and rivers that flow across the landscape, like experiences repeated over and over again, form neural pathways and neural highways in the brain. Ultimately, rain shapes the whole of our landscape. And just the same, experiences shape, or really build, the structure and function of our brains. We have evolved neuroplastic mechanisms that translate real experiences that each of us have in the world into meaningful changes in our brains and our physiology. Some of these mechanisms are epigenetics, neurogenesis, synaptic plasticity, and white matter plasticity. So how might a brain be organised if it has had experiences that are typically safe, predictable, and regulating? So if we've had many safe experiences and only infrequent experiences of trauma or adversity, if we've had stability and predictability, benevolent relationships that are emotionally and physiologically regulating, and experiences of being in safe and well-resourced relationships and communities where threat is rare, we'll have a brain that doesn't anticipate immediate threats and isn't preoccupied with survival, but is instead adept, having had a lot of practice, at planning and executive function, and a brain that anticipates and can capitalize on future opportunities. This brain will anticipate a future in which trauma and adversity will be rare if it occurs at all and manageable if it does. It will anticipate that planning will work and that making plans is worthwhile, and that soothing is available from relationships with safe people who know how to do it, and also that relationships and communities are safe and worth maintaining. But that's not how it is for all of us. So how might a brain be organised if it has had experiences that are typically harsh, unpredictable, and dysregulating? If we've had frequent experiences of trauma and adversity, lived chaotic lives, and if our families and communities weren't safe and neither were our earliest relationships, either through neglect or through overt abuse, we're likely to have a brain that is anticipating more immediate threats, is absolutely preoccupied with survival and regulation, but has had so few experiences of, and therefore opportunities, to develop parts of the brain that are involved in executive function and planning and looking out for future opportunities. We'll have a brain that looks a little like this. So this brain is going to anticipate more trauma and adversity in the future. It's going to anticipate an unpredictable world where planning is futile. So we adapt to become opportunistic and impulsive and to make the most of what's in front of us. It's a world in which we are vigilant and poised to respond to threat, knowing that the best form of defense is attack. And lastly, anticipating that relationships are often a source of dysregulation, we may discover that substances, alcohol, compulsive behaviors are actually more available and reliable ways to manage our emotions and soothe our distress. It's critical to remember that the same neuroplastic mechanisms have built these different brains from different experiences. And these brains are specialized to anticipate and survive in different environments. And this is what I call neuroecological diversity. There's no pathology here. The neuroplastic mechanisms are embedding experiences from the environments into our brains and under our skin, just as they evolved to do. One isn't sick and the other isn't healthy. One isn't good and the other bad. One isn't normal and the other abnormal. One is perhaps more fortunate than the other. Another way of looking at this is through this schematic. On the left are the neuroplastic mechanisms we have evolved over many lifetimes, and to the right of them are experiences that we have in developmental time throughout our development that allow us to adapt to the specific conditions that we experience. Harsh, unpredictable experiences, dysregulating relationships, and a situation where we have no power, agency, or control are likely to accelerate our development and orientate us to the present. This makes us more likely to take risks, to acquire resources, to bond intensely and impulsively, and to seek out short-term gains and immediate rewards. These outcomes are likely to ultimately shorten our health span and lifespan, but this is a successful strategy in that particular world, a fast life strategy. Contrast this with instead having benevolent and predictable experiences and relationships which provide soothing and are safe, and the kind of early environment that facilitates developing a sense of agency and control. Here, we'll develop a future focus. We can plan for the steady acquisition of resources because we live in a predictable world. We can decide perhaps how many children we can afford to have, and we can make short-term sacrifices that defer rewards and gratification to the future because we're likely to be around to collect those rewards. Our focus here is on the future benefits and the longer term. We can expect to have a longer lifespan and health span, and this is a slow life strategy. The neuroplastic narrative shows us that what brains and physiologies are supposed to do is adapt to the ecological niche that they develop in. A slow life history is a privilege, not a choice. So instead of judging fast life responses, we can work together towards social justice and for equity to change the ecologies from which the fast life adaptations emerge that lead to so many of the outcomes that we've tried to prevent. There's me. Do contact me if there's any questions.
Thank you so much, Hayley. As usual, I think that you've put the poetry in neuroscience. It's just been delightful, and I'm struck by a fast life adaptation as being truly an adaptation. So next we have Kelly.
Thanks, Bronwyn. Can you see that first slide?
I can see the slides. Thank you so much.
So my name's Kelly. I'm a clinical nurse educator at the Royal Children's, the RCH, and a trauma-informed preventative care area lead in the campus mental health strategy. So we've just explored with Hayley the neuroplastic narrative, and now I'm going to spend some time discussing perceptions of trauma and safety at the RCH and our focus on prevention. So in the biomedical model of healthcare, as shown here, commonly we refer to trauma as complex physical injuries which need urgent and intensive care. But trauma can also mean experiencing something deeply distressing. Through the COVID pandemic and lockdowns of recent years, there's been greater public awareness of mental well-being and social inequities, which has brought about a deeper understanding that whilst people can experience the same or seemingly similar situations, their individual experiences differ greatly. The poem excerpt written here was written by Damien Barr about the pandemic. He stated, "We're not all in the same boat, we're all in the same storm." And it was during the same time through the pandemic that I began reflecting on trauma-informed care in my practice as a paediatric nurse. I've included this video in my presentation to illustrate my reflections alongside some of my colleagues in community nursing. What are our perceptions of safety? Safe healthcare practices are clearly legislated and highly valued, but are not commonly thought of in terms of psychosocial, psychological, and cultural safety within a biomedical model. Just as the word trauma can have different meanings, considering what makes a space or interaction feel safe can require a different way of thinking. And safety is paramount for the health and developmental needs of children, for care, and for staff well-being. Trauma-informed care aims to increase safety and improve outcomes, which is a uniting goal for everyone coming to work or presenting to the RCH, to do everything in our capacity to support outcomes with vested interest in the health and well-being of children and young people. It is this commitment to children's safety and well-being which has shaped our definition of trauma-informed care. Across a children's campus, we have adopted the term trauma-informed preventative care. Clinical education aims to broaden perspectives of trauma and safety, and clinical tools support practical approaches. Many teams are driving forward trauma-informed preventative care across the campus, and I'm incredibly proud to say that nurses hold key leadership roles in practice and projects. As we expand our understanding of trauma and safety, we can begin focusing on prevention, building upon what we know about models of care and healthcare standards. Take, for example, a well-known preventative health practice, pioneered by nurses no less, hand hygiene. When I wash my hands, I don't make assumptions about my patient, my environment, or what I might transmit. I wash them because I understand that germs are common and that rigorous hand hygiene is a proven way to reduce risk for my patients, myself, my team, visitors, and even my family when I go home. Given the prevalence of trauma occurring in childhood and in healthcare, it is safe to assume that everyone we encounter is at risk. By integrating a trauma-informed preventative care approach in our interactions and environments, we establish a standard that promotes safety, trust, and well-being for all. I'll now bring you back to the storm analogy to finish. If we think of trauma and adversity like the boats at sea, we can understand how every patient and family will be differently equipped to navigate the storm of pediatric illness and injury. Metaphorically speaking, preventative care training will equip our staff to recognise patient and families' different boats. Knowledge and resources will help us to help them better navigate lives.
Thank you, Kelly. That was wonderful. I can see that we're using a bit of a water theme today because it's so apt. I just want to commend all the work that you've done around trauma-informed prevention. I think that's such a wonderful step and move forward and pioneering in that area. So thank you very much for your presentation. Next up, we have Ria.
Hi, Bronwyn. Thank you for that. And thank you everyone for coming along. Today I'm going to talk to you about trauma-informed care in cancer. And I'm one of the mental health liaison nurses working here at Peter MacCallum. And in order to explain what trauma-informed care in cancer can look like, I will mostly be talking through a case scenario. So can we have the next slide, please? So just as a snapshot, this is Peter MacCallum Cancer Centre. We are one of the leading cancer centres in the Southern Hemisphere, if not the world. And every year we see a snapshot of the 2023-2024 had us at about 47,000 patients treated, over 300,000 specialist clinic outpatient appointments booked. So we're very, very busy and we see a lot of people every year. Can I please have the next slide? So we've all spoken about trauma and what it means. We've spoken about trauma being a neurological in Hayley's talk, and then talking about trauma for children with Kelly's talk just before me. And it can involve directly experiencing a traumatic event, witnessing a distressing event, learning that something happened to a close friend or family member, or experiencing extreme or repeated exposure to aversive details of a traumatic event. People who experience trauma in early childhood are more likely to end up with chronic health conditions. One of these could be cancer. The trauma itself doesn't necessarily cause the cancer, but the experience of trauma itself can increase a person's risk for undertaking practices that can lead to cancer. And our experiences of this trauma will influence our behaviours, both negative and positive, which can include how we interact and receive medical care. Could I please have the next slide? So in talking about that, I want to talk about this particular case study, which I was quite heavily involved in as well. All information has been de-identified here. So let me introduce you to Alex, a 50-year-old patient initially treated with chemotherapy for a diagnosis of Ewing's sarcoma, which was treated successfully, and Alex went into remission for their cancer. Alex had previous experiences of trauma as a child and in early adolescence. However, 1 year post completing their treatment for Ewing's sarcoma, Alex developed a rare form of blood cancer, which was highly likely to have been a result of the treatment they received for this Ewing's sarcoma. Now, their pre-existing trauma experience also heightened their trust issues, which impacted their ability to engage with a new and more significant treatment process. And what I mean by that is that they had experienced trauma in the past and mistrust of healthcare services and professionals. And on discovering that treatment for their previous cancer had caused a new cancer, this already heightened that mistrust in the system. Alex had a lot of difficulty deciding about their treatment, deciding whether to continue with the treatment, and significant anxiety in the setting of these predicted long-term needs for hospital treatments. So a lot of hematological cancers, especially one that Alex had contracted, would need a significant hospital stay or a bone marrow transplant, or sometimes it's a stem cell transplant. I believe in this case it was a bone marrow transplant. And this would have impacted, up to a month of staying in hospital. Alex experienced significant stress around the thought of being trapped in a hospital setting, not able to get out and practice things that would help with their anxiety in the past, such as going for walks and being able to, they had a treasured pet at home that they liked to spend time with. And given all of this, their inability to decide on this treatment was also impacting their prognosis. So this very aggressive and life-limiting cancer that they had protracted without this treatment that they needed was actually decreasing their life. So they were going to end up dying if they didn't have the bone marrow transplant. So now that I've introduced you, I'll talk about what we did for Alex in trying to support them through their journey with a trauma-informed lens. Now, down the bottom, I've got this little slide that talks about how we can address trauma-informed, and it's got things like safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical and gender issues. So in doing this, we identified early this trauma history which could impact on their treatment, and it instigated a referral to the psychosocial oncology services really, really fast for this patient. We had a lot of open and honest discussions with Alex about what the treatment would and could look like. And in those discussions, there was opportunity for Alex to voice their own opinions on what they would like treatment to be. Very timely, as I said, linkages with the psychiatry and psychology services here at Peter Mac, and also support to, also access to things like the peer support network. We also got their family members and their people of choice who they wanted around them to support them in relatively fast. And you know, most of the appointments conducted had their supportive family members included as well. We did a couple of multidisciplinary joint reviews with both the inpatient haematological team, the Peter MacCallum haematological team, as well as the psychiatry and psychology services who were supporting. And we also took the opportunity, and, you know, where Peter MacCallum, we actually took the opportunity to go to the ward, which was at a different hospital to Peter MacCallum, and show the patient around what it would look like, what they might be able to do on this ward, and what, you know, services were available on the ward as well for when they were admitted. Next slide, please. So in looking at all that, we can see that using a trauma-informed approach, and I will tell you there was a very positive outcome for this patient. They were able to have that bone marrow transplant, and their hospital stay was not re-traumatizing for them. It really just highlights how in practicing trauma-informed care, we must remember to tailor how we approach every patient as an individual and consider their own personal, you know, circumstances coming into their treatment. It must be person-centered and individualized. We must founder around supportive relationships and trust, openness and willingness to share candor between health professionals, having those really open and honest discussions. And so our patients and our consumers don't feel railroaded when they're presented with, well, you're here, you need this treatment, and this is what it's going to look like. And especially with cancer treatment, because it can be really, really overwhelming and difficult to sit through. It must be strengths-based and recognise their own innate ability to survive and develop resilience and make meaningful decisions. This is about making sure they feel empowered and giving them a voice in their own treatment. And we must be inclusive and universal. Consistent messaging, having those multidisciplinary meetings was really helpful because every team member was able to have was able to understand the situation and able to have their input in around, okay, we can do this. How about we do this? And so in summing up all of that, I think it's just really helpful to highlight that what we do in hospitals and hospital treatment can and does impact people in a trauma sense. And I think we really, really must learn to tailor all of our services so that we can have a trauma-informed approach, so that we stop re-traumatizing our clients and consumers and we help them actually fully recover. Thank you.
Thank you, Rhea. That was wonderful. I'm so glad that we were able to benefit from Alex's story and that there was a great outcome for him or her, and that we were looking at I love all your musts, that we must do these things in order to not re-traumatize or perpetuate traumatic experiences. So thank you so much for that. We have Kelly Gum.
Thank you for inviting me to speak. I'm going to talk today a little bit about the challenges in informed care in actually looking after patients with traumatic injuries. My only declaration really is that I'm not a trauma-informed care expert, and I feel like I'm standing amongst giants here today, but I'm definitely on the pathway, and I really feel that there's a valuable role for us to be looking at this a little bit more closely. I work at the Royal Melbourne. We're one of the busiest trauma centres in Australia, looking after lots of patients every year with multiple and severe injuries from all over the state. It's not like the telly. It can actually be a little bit more challenging. Most hospitals we know are full of trauma survivors, and if patients didn't have a trauma history when they arrived, the traumatic event that occurred has just provided them with one. We know that patients with a trauma history have increased incidence of risk-taking behaviours, addiction, mental health, and family and interpersonal violences, which actually increases the risk of them being an injured trauma patient. And that's certainly the case for the major trauma patients that we see. You can see there's a quarter of them have addiction and mental health issues on admission. A traumatic event can actually be, a physical traumatic event can actually be a life-turning point in patients' lives. It changes them in many more ways that are more complex than just the physical. And I really think this is all about their change in status. It changes the way they see themselves, the way they feel that they operate back in the community. It changes their relationships with people. You know, this is permanent for a lot of patients. They may never return to exactly who they were before. The challenges for this in the acute care setting really begin with limited training and awareness. I know that trauma-informed care is not new, but it really is new in the acute space. Nurses are really just learning to identify and respond to the signs of trauma, which may be exhibited in ways that don't actually make sense to them. And without training, these might be interpreted and challenge caregivers. We see really high volumes of patients, and we have significant time restraints. The patients are complex, they're high acuity, and they rapidly move through our system. They only have an average length of stay of 3 days. And then we're looking at patients who have the burden of trauma on trauma. So patients with a trauma history coming in and sustaining a physical and sometimes psychological trauma, depending on the circumstances of what brought them to us. Not only how they may have injured themselves, they may have injured someone else, or someone else may have lost their life. This can be really challenging for healthcare providers to provide compassionate, individualised care. That's really important for trauma-informed care. The hospital environment doesn't really help us out. Even in on newish wards, we're really not set up for trauma-informed care. We don't really have many single rooms. We don't even really have spaces to have confidential conversations, and this has worsened since COVID. It's hard to have confidential conversations. There's mixed cohorts of patients. These are mixed genders, ages, conditions, and acuity. And it can be really noisy and scary whilst trying to recover from a traumatic injury. And this is worsened if they have a trauma past history, and some of these things would trigger some of the issues. Staff burnout and compassion fatigue is real. Our staff are frequently exposed to trauma. They're constantly hearing and seeing the results, hearing patient stories and seeing the results of their traumatic injuries, whilst managing their own trauma if they have some. We see compassion fatigue really reducing empathy, and that makes it hard to stay in a trauma-informed care framework. I really think too that empathy reduction is used as a coping strategy, and I definitely have seen that in some of my own practice over the years. Challenging behaviours are really becoming our biggest issue, I think. Patients, particularly who've experienced trauma, may present with behaviours that may not communicate how they're really feeling, but sometimes these behaviours are noisy, erratic, and they can feel frightening to those who are trying to care for them and support them. So instead of stepping up to them, sometimes we step away from them. We've got a growing multicultural society. We're seeing increased numbers of patients from diverse backgrounds and who have unique trauma experiences, and that can really make it a challenge to navigate without cultural competence. And language barriers is a massive one. It really makes it hard to establish trust when you're trying to have a discussion about their basic needs over Google Translate, let alone trying to find out more complex information about their past history. So it just makes it hard to provide sensitive care. So what can we do? I'd really like to think that we can look for the glimmers, looking just for small opportunities to build trust and to make our patients and us feel safe. We can do some really simple things, which we do every day, which no one really realises is actually part of trauma-informed care. We're going to orientate our patients to the ward. We're going to let them know who the staff are and what a typical day might look like, really establish what matters to that patient and work towards achieving that. Make sure that we're accountable, following up on any action that we say we will. And if we can't follow up on that action, go back and let the patient know. We want to provide the patient and family with information that's easily translatable. We have a brochure with a little picture of a man, and we write down the injuries in plain language and what the treatment will be. This really helps make the patient feel safe and helps build trust. And we want to encourage them to ask questions. Sometimes it can be overwhelming. Our trauma patients could see 5 or 6 different teams, and each of those teams could have 5 or 6 members in it. So we just encourage them to write down questions at any point during their care so that when the team arrives, they have easy access to them and they don't forget. We'd like to provide the patients with choice about what's going to happen if we can. Request permission before intervening in any of their care, and try and encourage and support their autonomy, even if it's just small steps. Engaging with the family is really important. They're as integral to the patient's recovery as the patient is, and they can also help us get to know the patient. If we learn a little bit about who they were before the hospitalisation, what did they like to do, what did they do as a job, who were their family, what's their pet's name, it can help us relate a bit better to the patient and to get to know them and to build a little bit of trust. And in our time-poor situations, we can reach out to the multidisciplinary team to provide a little bit more support if the patient needs. And of course, we need to engage with the interpreter services for those with a non-English speaking background. For nurses, I guess it's the same stuff we all should know. We need to really monitor our own triggers, seek support from our managers, and use all of our wellness resources in each of our individual organisations. I really think, having done all this work up until now around this, that the TIC framework really relates to the fundamental principles of patient-centred care and therapeutic relationships, which is embedded in nursing practices. Our intervention should be styled to focus on creating a safe and empowering environment for the patients, where those who've suffered can really learn to survive, and using the RMH values, leading with kindness and putting people first. Thank you.
Oh, thank you so much, Kelly. That was a whirlwind tour through a whirlwind, chaotic kind of environment that you're doing incredibly good work in. And I like the fact that you've gone back to nurses are positioned and placed perfectly to create changes in this environment. And they don't have to be big, gigantic ones. They're about those very core skills that you're speaking about. So thank you so much. Claire Manning, you're up next.
Thanks so much, Bronwyn. And I have to say the culmination of these presentations is quite lovely, and lots of links and synergies. So welcome, my name is Claire. I'm the Director for the Social Model of Health at the Women's. I started at the Women's approximately 4 years ago now, and had previous clinical experience working a range of drug and alcohol, child protection and child and adolescent psychiatry, particularly with high-risk adolescents. And these clinical experiences have certainly shaped my understanding of the impacts of early childhood trauma, including sexual abuse, physical abuse, family violence and neglect. And upon joining the Women's, it was really clear that there was an opportunity for a cultural change piece regarding trauma and violence-informed care. So when considering the Women's, considering the cultural change piece at the Women's, I really reflected upon 3 key factors. Next slide, thanks. The Women's provides specialist maternity, neonates and women's health care to women across the state of Victoria. And our values are really kind of embedded in our history, and that is paramount to us in providing equitable health care, and certainly ensuring that those of socio-economic, cultural disadvantage are not disadvantaged when they're receiving healthcare. Next slide. 87% of our workforce are women across both clinical and non-patient facing roles. And this placed us actually in an extraordinary and really quite unique space to consider the impact of trauma upon our entirely female cohort, but equally when we're looking at our workforce. Next slide. And the third factor I really considered in terms of our next steps is that the Women's, in conjunction with Bendigo Health, has been the statewide lead for the past 10 years regarding strengthening hospitals' response to family violence. And during that time, we have trained approximately 2,000 staff, and they are just kind of the women's figures, in recognising and responding to the signs of family violence. And during my conversations a number of years ago with Professor Kelsey Hegarty, who's co-chair of family violence across the Women's and the University of Melbourne, we really decided to focus and really maintain and build upon the family violence work that had been undertaken and have a very strong gendered lens. Hence, we started the conversation about trauma and violence-informed care. Next slide. We took a fairly honest analysis of where we were at the Women's, and I absolutely felt that there were certainly pockets of interest of trauma and violence-informed care, and conversations were certainly starting, but I probably felt that as an organisation, we were sitting down on that left-hand side of the continuum. Next slide. So in 2023, we started a range of conversations, and these conversations occurred across both clinical and non-patient facing staff and across a range of disciplines. If we could have those stats just rolling through, thank you. So as part of the consultations, we started providing our workforce with some fairly confronting statistics for many of our staff. And we really wanted to start to, ascertain what was the level of interest and equally what was the level of understanding regarding trauma and violence-informed care. And we really took the opportunity to start to demystify perhaps some assumptions that were there, or the pathologising understanding of who may have experienced a trauma. Next slide, thanks. And during some of these conversations, we really started a narrative about more leaning towards that trauma is perhaps more of the norm and not the exception. And if we look at that middle box, about at the heart of trauma are two key components, and by no means am I kind of minimising or nor am I simplifying the impacts of trauma. But one of the things I was really keen to promote with in these conversations was that there are two key tenets. One is that loss of control in a traumatic experience, whether that is a singular trauma experience of a bushfire, a car accident or flood, or repeat experiences of perhaps early childhood trauma. There's a loss of control and a fundamental breakdown of trust. And when we're thinking about this for the relevance of our of how we provide our healthcare, those two same components are often appear when we go into hospital. And I think for all of us, if we reflect on our own experiences of attending hospital, we do have to hand over a great deal of trust to our healthcare providers, and equally we have to hand over control and trust that the people are going to be able to take care of us. Next slide. So during our discussions, my apologies, this might be a little bit small, we really focused on the strength of trauma and violence-informed care model. And if you see one of the bottom boxes, we really promoted that staff don't need to be an expert in understanding trauma to provide trauma and violence-informed care. And similarly to the link that Kelly had made in the earlier presentation, we too equally focused upon that kind of metaphor of hand hygiene. We can't always see the bugs, but we know that the bugs are there, and hence the good practice of hand hygiene. We equally listened to strongly listened to our workforce about what they felt they needed. And our workforce were really clear in telling us that they wanted a foundational level of training package that was online, it was easily accessible, and that if needed, people could dip in and out of. Next slide, thanks. So our e-learning training package covers the principles of violence-informed care. It has an interactive learning component. It absolutely recognises staff self-care and the impact of vicarious traumatisation for our workforce. We have a range of scenarios, and again, de-identified. And I will add the trauma and violence care informed videos was an additional piece of work that we undertook during 2024 in conjunction with the University of Melbourne. And that is actually embedded into the e-learning training package. Next slide. And in December last year, smack bang in the 16 days of activism, we launched on what's called our WISE, our e-learning training platform, the modules. We popped these up on our screensavers, and these were popped up throughout our hospital. Just the next slide, and you'll see here, just on the left-hand side, making care easier, trauma and violence informed care. So that's a specific tab that's been set up on our intranet for our staff. If we go to the next slide, and within there, not only do we have the eLearn training package, but if I can draw your attention, and very, very happy for these links to be certainly circulated. We have a number of videos established on this website, and we are in the process of developing a few more. So we're very much hoping that this our intranet this isn't going to be a static platform, and that we'll continue to load up resources as they come to light. And our e-learning training package is available via request through Strengthening Hospitals' Response to Family Violence until we can get that up on our new internet and circulate that more broadly. So thank you, Bronwyn. And sorry, and these are some of them. Obviously, our next steps is continuing to circulate and promote our slides in our e-learning training package.
Thank you, Claire.
Thanks, Bronwyn. That
was fantastic. What a lot of work you have been doing in that space. And I'm just completely struck by it's a hospital for women of women, and it's rather extraordinary the work that you've done. So thank you to all our presentations this evening, and we're now going to open up to a Q&A for the panel. So if all the panel could come on camera. And my question is actually to Ria. Ria, you kind of told us a tiny bit about why going to hospital was in particular was I suppose traumatic. But I was wondering if you could expand upon the traumatic experience of cancer patients, so we can really put that in context, if that would be okay.
Yeah, thanks, Bronwyn. So I suppose what I mean by that is that the experience of a cancer diagnosis can be traumatic in itself, in that explanation of trauma being a life-threatening event. Cancer is quite a serious and a health condition that requires quite significant treatments. And when you think about chemotherapy, radiotherapy, and what that is actually doing to the body. So with chemotherapy, you often have quite neurotoxic drugs, cytotoxic drugs, my apologies, going through the body. And then with radiotherapy as well, you're basically killing cells through the use of, my very simplistic explanation, these, very targeted light beams and things like that. And as well as some of these actual procedures being traumatic in themselves, people with a head and neck cancer will often have to go through these big processes of going in machines and wearing very, very restrictive face masks, as well as, after the treatment, people often have this long-standing fear of cancer recurrence. And they might get things like, we have a term that I'm not sure if it's actually coined by us, but it's certainly a term that we use quite a lot, scanxiety. So lots and lots of stress and anxiety around these recurrent scans that people have to have when they're in remission to make sure that their cancer hasn't come back. So the actual experience of cancer is constantly in the background, constantly impacting them and causing them to keep remembering and recurring all those experiences of what they had in treatment.
Thank you so much. It just also reminded me of I was thinking about Hayley, and you're thinking about people who are adapting to their trauma experiences and then being put in machines where they have to be kept very still. It's kind of a culmination of trauma. But rather than me dominate by asking all the questions I'm interested in, perhaps we'll take it to some of the questions that are here, if that's okay, to the panel. We do have a question from Stephen McKeever, who's wondering about, do we have any specific advice regarding trauma-informed care with Aboriginal and Torres Strait Islander peoples? I'll just throw that open to everyone.
I'll be brave.
Thanks,
I'll be brave and say the key project I was involved in the campus was creating our foundational e-learning, which I didn't focus on in my slides, but one of the little pictures was of that. And that was over 12 months of co-design development with lived experience with people who had been patients, people who had been parents, people who worked and had their own lived experience, and people that worked. So that was a really big collaborative input, and we really needed to have lived experience of Aboriginal and Torres Strait Islander people in that. And in our learning, we have our wonderful Wadja team who are such keen advocates, but also they're the experts. They're living and breathing this and actually understanding what it's like being in government organisations, that loss of control and the historical and intergenerational trauma is something that we need to hand over to the experts. So you need to have that lived experience and that professional experience of Aboriginal and Torres Strait Islander people.
Thanks, Kelly. Does anyone else want to add to that? Excellent answer. I think the co-design is absolutely imperative, as you said. Anyone else want to add to that? Okay. We had I suppose a bit of a contentious question, which I think that rather than my pondering it, I'll throw it up into the panel. But the idea, people are totally committed to the idea of trauma-informed care, but the principles of trauma-informed care seem difficult to implement consistently in practice. Given the complexity of trauma and diversity of individuals who have experienced, do you have any thoughts about trauma-informed care can truly be standardised across healthcare and professionals? Who'd like to have a go? Claire?
Yep,
I can,
I'm good.
sorry, go on, Kelly.
That's all right.
Then Kelly has that.
Sorry, shall I jump in? I think for me, what really jumped out kind of with that question is probably the notion of standardising. And for me, I guess, when I'm thinking about trauma and violence informed principle, in many respects, it's the principles that are, for me, most important to adhere to. And then it's about the nuance of how that might be provided. I don't always think it's necessarily contradictory, though, to a medical model. And I actually think there's a real opportunity kind of for a medical model. And I think increasingly as the medical model is really shifting towards really the importance of recognise the importance of lived experience and collaboration and building sort of safety and trust. So I think if we can stick to kind of adhere to the principles, then we can then kind of build some of the nuance.
Thanks, Claire. Hayley?
Were you talking to me, Bronwyn?
Yes, I was, Hayley, sorry.
Oh, sorry, I can barely hear you. I don't understand why, but I can barely hear you.
I will lean closer to the computer. That could be it.
So look, the only point I was going to make is that I think, like Claire said, the principles are important, but the trauma that people experience is never like one thing. Someone's experience of physical abuse is not the same as another. Someone's experience of emotional abuse or sexual abuse or neglect isn't the same as others. And some people feel that they don't even fit in any of those categories. And I'm one of those people. And so I think when we're carrying, one of the principles we're carrying is that be alert to what the individual is letting you know. And that's not always easy because there are great numbers, but I think that's a really important thing to hold on to.
I guess I love that, Hayley. To add to that, I think it's not making the assumptions, because we're very good and we're very efficient at having checklists, and generally that provides a safety of care because we know that we do these things because it's evidenced and because that's what gets good outcomes, right? When it's something that's very tangible and clinical. But actually, you could say, oh, we go into a space, we make it trauma informed by turning off all the lights and making it all really quiet. But if you have a child where every time that happens, something bad happens, that is not going to be a good approach. So actually, by trying to standardize in our approaches, we end up with care that isn't differentiated. So what we mean by standardizing is actually asking the question, removing assumptions, passing that ownership over to families and children, and allowing them to tell us what they need and what makes them feel safer.
We are running out of time, aren't we? But I think I have time to ask one more question from the list. It was just around birth trauma. Claire, particularly, I think it's towards you, your area. What are we doing in your trauma-informed program regarding birth trauma?
Lovely. Yeah, thanks, Bronwyn. And certainly that was one of the statistics that I put up is about the experience of birth trauma. So certainly in the kind of social model of health, we've equally been partnering quite closely with our kind of director clinical and medical in the maternity space, and really listening to kind of women's experiences in terms of birth trauma. And we do offer certainly a program at the women's, and again, it's working strongly from that assumption. Without having that assumption of what is a traumatic birth. So it's actually about listening to the woman's experience of what she may have found and she may identify as a traumatic birth, and then offering certainly those additional sort of follow-up times. But I think that's an additional area for us to continue working on. Incredibly important question.
Roman, you're on mute.
As I say, I've only been used to this material for a day. We are finishing up for time, aren't we? So I just want to say that we are recording this presentation. This presentation will be uploaded to the nursing website, so you'll be able to get hold of, watch it again or share it amongst your colleagues. And in terms of slides, if you're interested in slides, it might be something to directly email the speaker that you're interested in. But I just want to say thank you to all the presentations. They've just been wonderful and diverse and so engaging. So I just want to hand over back to Kathy. Thank you.
Thank you, Bronwyn. Thank you, everybody. Tonight's been very popular. We've had about 15 questions we haven't got to. We've had about 250 people join us throughout tonight. So it's been a really popular topic tonight. Thank you, everybody, for coming. And I would just like to remind everybody about the next event, the Marion Barrett Lecture. There is a presenter, Professor Dawn Dowding, and she's going to talk about data and digital systems, improving equity, safety and efficiency in nursing practice. This will be a face-to-face, but there will be an online option also. And post-lecture, there'll be networking canapes, and there'll also be our prizes and awards ceremony this year. We're doing it slightly differently. So we really look forward to seeing you in person at that event. And thank you again for all of our speakers, and thank you for joining tonight. Thanks. Bye.